A very nice morning to all of you. I'm going to speak on definitive airway management in pediatric mandibular hypoplasia with mandible distraction osteogenesis. I'm Dr. Rakesh Sharma, Professor and HOD, Department of Maxillofacial Surgery at Lady Hardinge Medical College. Well, I am presenting a clinical scenario. You all can appreciate a baby with severe difficulty in breathing, having multiple episodes of apnea during the sleep, not able to sleep even in the prone position. And saturation is showing 55, 60. Now, where is the problem and how to diagnose it? The problem is the respiratory obstruction, which can be at the supraglottic or subglottic region. It can be tracheomalacia, laryngomalacia, any lung anomaly or any infection or central apnea. My focus will be on hypoplastic mandible, which leads to displacement of tongue posteriorly and then the obstruction of the posterior airway space and leading to hypoxia. The pre-treatment diagnosis is by radiographs. A true-lateral neck X-ray can show the space between the base of the tongue and the posterior pharyngeal wall. And it can be supplemented by CT and MRI scans. Vital parameters like SpO2 also can tell, and jaw index. But the true real-time dynamic evaluation can be done by endoscopy, I feel, bronchoscopic evaluation, which can tell us the degree of obstruction, whether it is supraglottic or subglottic, as well as the component of laryngomalacia, tracheomalacia, any subglottic mass. So this is the must diagnostic aid to diagnose the problem and degree of severity. Jaw index is another parameter that can tell us some degree about the hypoplasia and the degree of hypoplasia of the mandible or shortening of the mandible compared to the maxilla. And this can be categorized into mild, moderate, and severe. The mild cases and the moderate cases can be managed by some appliances, orthodontic appliances, or positioning or conservative methods. But the severe cases require surgical intervention most of the time. But these mild and moderate cases can anytime convert into severe cases because the mandible is not growing parallel. It's not growing compared to the normal skeleton. It is having an inherent deficiency in the growth. So it can lag behind the growth anytime, and these cases can again turn up to severe. So mild and moderate cases require a very good follow-up. Now, how to manage the supraglottic problem? We have various options. Primary management by positioning, CPAP, BiPAP, or may require intubation in severe cases. Then tongue lip adhesion. Tracheostomy was the earlier gold standard for management. Distraction osteogenesis is the true method for advancement of the mandible, and we use this method. Osteotomy was done, and then these devices are used to advance the mandible. This is fixed, and then two arms in the two segments, and then it is activated. So we present a case series of 20 cases. Out of those 13 cases were severe cases. This is the surgical technique with classical submandibular incision, preserving the neurovascular bundle and structures and fixation of the device, osteotomy, and advanced. Although studies say that ideally 1 millimeter per day should be done, but at our center we are doing 4 millimeter, 3 to 4 millimeter per day. It's a fast distraction so that we can achieve extubation faster if the child is intubated. The outcome variables are the changes in the posterior airway space, oxygen saturation, later on weight gain, as well as improvement in jaw index. We had a combination of syndromic and non-syndromic cases, and as per the severity and the results. And we have done on an average 10 to 15 millimeter advancement of mandible by this technique. This was case 1, which we did in 2014, and this was the external distractor that we fixed, and then after the removal of distractor, and this baby, child has grown up. And this is second case. I didn't want to make it a surgical presentation, so I posted only 2 cases. This was a very interesting case. It was roaming here and there with the problems, and at other institutes, it was diagnosed as laryngomalacia. or tracheomalacia, but at our center, bronchoscopic evaluation was done, and it was found that main problem was at the base of the tongue, and it was advanced. So I would like to conclude by saying that a quick clinical screen, supplement of radiographs and MRI, and followed by surgery can lead to actual advancement or expansion of the posterior airway by distraction. Some complications were there. There was infection in one case and fracture of mandible in one case, and we also had lung collapse because of endobronchial intubation, hardware failure, and hemorrhage in one case. At the end, I would like to thank my team, surgery team at my department, anesthesia team of LHMC, pediatric department, ENT, and special thanks to our pediatric pulmonologist, Dr. Professor Vrinder Singh sir, who is the driving force behind all this work, and his guide. He is always there as a mentor to help us. I am thankful to the forum for allowing me to present this paper. Thank you.
Thank you for that. Any questions in the audience?
Unique experience shared by you. Sir, another operative maneuver that is tongue-lip union.
Yes, sir. Yeah.
Have you ever tried it? It is a relatively simple one.
Sir, I have tried in some cases, but it works in mild to moderate cases. But in severe cases where there is no space at all, by tongue-lip adhesion, tongue moves only little bit. So the true method is distraction only that will actually bodily move the tongue forward. In 2 cases we tried it, but then one case came back after tracheostomy, again came back to us, then we had to advance it.
Thank you.
Yeah, and could I just ask, we use nasopharyngeal airways a lot in the UK for this sort of case. Do you ever try those? Because
Sir,
we found them to be very successful, particularly in Pierre Robin.
Sir, our pediatric team have tried all these things at our institute. So as I told you that mild to moderate severe cases can be managed by these airway maneuvers, but severe cases where we have to at last intubate it, those cases will require extubation somehow. The mandible is so much behind that there is no space for the baby to breathe. So we have to move the mandible forward so that tongue can come forward. And even in some of the cases which were managed conservatively by these airways and all, some cases come back after 3-4 years for the surgery. One case was managed conservatively, but at the age of 4 to 5 years, the baby came back, and then she was having severe apnea, and we have to advance the mandible then at the age of 5 years, which was managed at 2, 3, 4 months, 1 year, conservatively only.
Okay, thanks very much.
Thank you. I just have one other question.
Sir.
We, in Brisbane, Australia, we have published it way back in 98 onwards. We do nasopharyngeal airway even for the severest of ones. And there is a large case series that will soon be published. Only two patients of us went for the surgery. Is there a particular age at which you choose to do surgery when you do mandibular distraction? Is that at what age do you operate on the baby?
Sir, that depends on this. I feel that depends on the severity of the case. Some of the cases there was no way, either we have to go for tracheostomy or we go for intubation, but we can't get a baby for prolonged intubation. So the earliest baby was operated was 20, 30 days old.
Okay.
There was no other way to bring the mandible forward. Some of the cases are so severe that our pediatrician are not able to put the scope inside.
Yeah.
The
So
tongue
you
is
end up
pushing
doing tracheostomy.
so those cases, that's the only way to advance, lengthen the mandible, because the problem is there. It is not in the soft tissue or the tongue. It is in the mandible, which is having the tongue. So we have to move it forward. And in that second case which I have shown you, that case has gone to very renowned places. And there it was diagnosed as laryngomalacia, severe laryngomalacia, and they were planning some procedure also. Somehow case came to Varinder sir, and then he did the bronchoscopy. There was not much degree of laryngomalacia. Then he referred the case to us. I advanced the mandible by 10 millimeter. After 10 also, the tongue was not moving ahead as you think. Then I had to do more correction, overcorrection, 25 millimeter.
I would like to discuss later on after this session finishes because I'm interested. And
only one comment why I was requesting my colleague from maxillofacial to be here in a pediatric pulmonology. We did all that for several years, nasopharyngeal airways. We tried creating our own tongue stitch and tongue and lip adhesions. They are all temporary measures. And with the background infection rates we have, these children often come back, and they come back in such a bad shape that a regular resident sometimes finds it difficult to even intubate them because
Okay.
it's totally distorted. This intervention is something which brings a very dramatic relief, and it's long lasting. Even if I do nasopharyngeal airway, whatever I do, these children are at a risk of OSA later on.
Yeah.
This is a definitive therapy, and it saves a lot of interim steps. So that's why we are ready.
Do-
Thank you.
Just one last question. Do they run into any problems later in life with dentition and things like that? Is there a...
Sir, as some of the cases we have done overcorrection, so the mandible has come forward now ahead of maxilla. So at later on, these cases may go into class 3. But studies show that the mandible has inherently less growth potential in syndromic PRS, Pierre Robin sequence, and tracheal syndrome cases. So after some time, they come back. The mandible, even if you have done overcorrection, it will come back to the normal. But some longer, maybe 10-year or 15-year follow-up may be required for our cases. Our latest, the maximum follow-up is of 10 years. So that baby is good, doing good. There is no problem in the dentition.
Great.
Thank you.
Lovely. Thanks for that.